Hi, I'm Erin Power.
And I'm Laura Rupsis.
We're certified health coaches, and this is Health Coach Radio.
This podcast is about the art, science, and business of health coaching.
We share our insider tips to help you become a better coach and entrepreneur.
And we interview expert guests to discover how they've made it in this growing field.
It's time for health coaches to make an impact.
It's time for Health Coach Radio.
Today's guest is Dr. Ken Zweig of the Northern Virginia Family Practice, a membership-style concierge medical practice, a model we're hearing more and more about because it helps patients move the dial on the behavior change necessary for health improvement by factoring in longer, more intentional doctor visits, plus care from an allied team that may often include nurse practitioners and health coaches, which helps keep patients moving toward their desired and personalized health outcomes. In 18 years of working in a variety of medical settings, Dr. Zweig says no healthcare setting has been as patient-oriented as concierge internal medicine. Dr. Zweig believes the majority of medical problems are caused by poor behavioral habits that have accumulated over time, and wouldn't we agree, health coaches? He takes a preventative approach to treatment and helps patients adopt a preventative behavioral mindset before relying on medication that could inadvertently cause other medical problems. His big focus is on sleep disorders and hypertension, which goes hand in hand with his mission to improve patient health through behavioral change. He also helps patients improve their overall mental and physical health through a holistic approach to treatment that focuses on nutrition, exercise, and managing stress. So Dr. Zweig is right in our wheelhouse, and this is a great conversation for health coaches looking to break into a medical practice. Our show's sponsor is Primal Health Coach Institute. We're a health coaching school that provides aspiring and existing health and fitness professionals with the training, resources, and support to make a lucrative living, changing lives. We've got thousands of graduates practicing unique coaching specialties and changing lives in countries all over the world. Visit primalhealthcoach.com to learn about all of our coaching and specialty certifications, including the Primal Health Coach certification course, the Primal Fitness Coach certification course, and our Master Coach certification course that satisfies the educational requirements to sit for the Health Coaching National Board exam. And also keep checking back as we launch more and more specialty programs, including our Launch Your Coaching Business course, which will nurture you to create and sell your signature health coaching program. We even have more courses coming down the pike soon, so if you're really interested in functional therapeutic diets, the human intestinal microbiome, strength training for women, or learning how to be a health coach in a medical practice, keep checking back to our website and sign up to our email list to be the first to find out when these outstanding new courses drop. Visit www.primalhealthcoach.com and check it out. And while you're there, you can also learn about our done-for-you 12-week coaching program delivered to your clients via smartphone app. So learn more about Primal Pro at primalhealthcoach.com/Primal Pro. As you're listening to today's show, make sure to screen grab your podcast player and tag us in your Instagram stories at Health Coach Radio. Don't forget the show notes for this episode, and all previous episodes can be found at primalhealthcoach.com/radio. Dr. Zweig has a lot to teach us about how to help our clients advocate for themselves within the healthcare setting, so let's get on with the show. Please enjoy this conversation with Dr. Ken Zweig.
All right, today we have Dr. Ken Zweig in the house, aka Dr. Z. Thank you so much for joining us. How are you?
I'm great today. Thank you so much for having me.
Oh my gosh, we love talking to practitioners. We love talking to everybody. Hey, Erin, I just enjoy every episode, but we particularly enjoy talking to practitioners and other health coaches and really kind of getting into the nitty gritty of helping clients change, which is awesome. So, but you are a practicing doctor. So would you mind giving everyone a little bit of your background, who you are, where you started in this process, and what led you to how your practice is today?
Okay, great. So I grew up in Pittsburgh, Pennsylvania, and I come from a family of physicians. So my father was a physician, my brother was a physician. I have a lot of uncles and cousins who are physicians, and so just really in the family. So there was no avoiding it, even by my best efforts. And I went to Ohio State Medical School and then residency at Georgetown University in Washington, D.C., which is basically where I still am now in Arlington. And I came to really focus on behavior change through a few different ways. It was sort of an evolution. I found myself seeing a ton of patients with basically just high blood pressure. And I thought, well, let me get to the bottom of why, it's such a common thing and all we do is give them a medication, but what's really behind this? And I started looking into it and found, sleep was a big part of what leads to high blood pressure. And so I became really interested in sleep and sleep medicine. And as I looked into that more, I realized that sleep was really a key foundation in the bigger picture, which is just all behavior health. So, as it sort of evolved, I realized, I never really got a lot of training in this. I don't know how to, I know what people should do and I know to tell them to do it, but I don't know how to get them to do it. And so over a number of years, I started looking into it more and more and became more interested in it and found that, yeah, there's a lot of information about it out there, but it doesn't get to the people who probably need it. And so I did my own research and I've become really interested in it. And I use that a lot in my practice now. That's how I came to be really interested in behavior change.
You already, we're like 1 minute in, and you've just delivered a soundbite that I love, which is, I know how to tell them to do it, but I don't know how to get them to do it.
Yeah.
Yeah, exactly. And that's the problem. Yeah.
That is the problem, 100%. I just want to acknowledge you because in this very abbreviated origin story, you shared something that I think is really great, which is even as a trained and licensed physician, you were seeing hypertension come in and you thought, what the heck's going on here? And seeked to understand and found a link to sleep. And what I liked about that is in sort of my health origin story, which I'm not going to get into, what I had a really I had the opportunity of a doctor that did the same thing, that said, this doesn't make sense. Check out stress. Stress might be your thing. That was the first time in my lifetime that a doctor had suggested something outside of the clinic or outside of my body might be the problem. So really interesting. I just wonder, I mean, coming from a family of physicians, are you like a black sheep in the sense of like approaching it this way?
Well, I think I'm a black sheep in other ways in my family, but it's hard to say because I'm actually much younger than everybody else. My brother is 8 years older, and obviously my father's already retired, and so I think this is more of an evolution of medicine. Back in the day, you have a problem, here's a pill.
Yeah.
And that's sort of really just how it was taught and how it's been perpetuated. And so I guess I am a little bit of a black sheep in that way, just because I'm a younger generation. I hope that's the case. I don't actually I talk to my brother a lot about medicine, but I don't talk to him about really how we practice maybe. It's hard to say if I'm a black sheep in that respect or not.
I like your answer better, that it's not a black sheep thing, it's an evolution thing. Let's go with that.
Yeah. I certainly hope that's the case. And I think it is.
Right.
Yeah.
Yeah.
I wonder how much of this too is your own personality and curiosity of being like, this is kind of weird, and researching something other than medication and trying to really get to the root. I would love if you wouldn't mind sharing us a little bit of that journey on how you made the connection between hypertension and sleep.
So I didn't make the connection. It's in the literature. And I just I try to read as much as I can. And I think I started practicing. Like I said, not very little of this. Basically, almost none of this came from my medical education. So this was all on my own doing it. But I really started practicing around the time when sleep medicine was really taking off. I don't know if you noticed this around where you were, but there was a point in the early 2000s where all of a sudden everybody decided that everybody has sleep apnea, and all of a sudden all these sleep clinics started showing up everywhere. They started popping up like Starbucks. It was amazing. I mean, every other corner was a sleep lab. And so I was interested in why is this happening? And so I started looking into that and realizing, there's all these associations with sleep apnea and high blood pressure and diabetes and heart disease and strokes and all these other things. And so I became interested in that, and the more I looked at it, I realized that it's not just sleep apnea, it's really any sleep disorder. Anytime you just don't get adequate sleep, whether it's quality or quantity, it leads to a lot of medical problems, partly because when you're tired, it's hard to do the things you're supposed to do. Nobody, when you're exhausted, you're not going to get up and go exercise. When you're exhausted, a piece of pie sounds a lot better than a salad. So, that's part of the problem. There's a lot of other reasons behind it. But I started really being interested in sleep. And like I said, as I started looking into that and why it was and how sleep impacted your ability to exercise and diet, I realized that it's more factors in that as well. And actually, I have a good friend who is a ultra marathoner. He's just an absolute fanatic when it comes to exercise. And he said, I don't buy your sleep philosophy. He goes, I don't think that's the case. He said, I'm in great shape. I exercise all the time and I only sleep 5 or 6 hours a night. And so this was a few years ago, and it got me to thinking. And I realized, really, I think that there's three. It's a three-legged stool. It's diet, it's exercise, it's sleep. And if you are amazingly good at one of them, it probably can counteract parts of the other ones. Ideally, you want a stool that's even on all three legs, right? But if you do one of them really, really well, you might be able to get away with not doing as well in one of the other areas.
Nice.
But you want to do the best you can in all three. And I always add a fourth leg is that, eat right, exercise, get enough sleep, and don't be stupid. Don't drink too much, don't do drugs, don't smoke, those kinds of things. So but that one's
avoid poisonous things. Is that one of our rules in Primal? Avoid dangerous.
Is that right? Avoid poisonous things. Good.
Yeah,
like
Mark Sisson has his 10 laws, and that's one of them. Avoid poisonous things and avoid stupid mistakes. Those are two separate laws. They could probably.
two separate. Yeah. I like.
We needed a nice round number of 10. It made sense.
Right. Okay. Fair enough.
But what's interesting with that in terms of this sort of trend towards sleep medicine is the sheer increase in volume of sleep medications prescribed. My mother-in-law has been reliant on Ambien for years. My husband, who has, by the way, suffered from alcoholism and anxiety, depression, and ADD, ADHD, and instead of folks really working with him on perhaps some of the underpinnings of that, it was, well, here's some Lunesta. Let's see if we can get your sleep in order by making you unconscious so that you're not, aware. And then hopefully that kind of helps make other things. So it's still sort of, what I find interesting is in terms of that shift towards sleep medicine is you were drawn to behaviors and habits and different choices instead of just medication, which seems to be a knee-jerk reaction for not all doctors, but a lot of doctors. And a lot of it's, to your point, you were talking about this before we recorded, it's the educational system.
Yeah. I mean, it's called medicine, right? For a reason, because that's where our focus is. I would suggest that that's not a great name for what we do, because it should be behavior change first and foremost. And so, but it is a knee-jerk reaction. Part of the problem also is, one, it's the education. Two, it's the time. It's so much easier to write a prescription than it is to sit down and talk to somebody and explain why they need to do this and then how they need to do it. It takes a lot more time to do that, and doctors just don't have that time.
Right.
So, yeah, if you think from a system standpoint, doctors are compensated in volume and number of patients they see rather than on outcomes and the success of the client and things of that nature. That's, I think, probably, and the one practice that I'm aware of now that is trying to change that paradigm is VertaHealth. I don't know if you're familiar with them, but I
know there's a lot of them out there that are trying to change the paradigm.
Yeah, so they focus predominantly on type 2 diabetes. They include health coaching as part of their treatment protocol, and they've reached out to insurance companies with this deal, like being compensated for getting people off medications, reducing, certain metrics and things of that nature. And it's next to impossible to do that in the conventional medical system, far more likely to do that in more of a concierge model like you're doing in terms of how you're compensated and how you see patients and things of that nature. So I would love for you to speak to, have you always had that model, that concierge model? Did you make a change, and what was it that prompted you to make that change? How did that happen? Would you mind giving us a lowdown?
Yeah, absolutely. So this is something that I don't know, both of you can attest to, because it's different in Canada, obviously, so you're probably not familiar with how things are going here, but it's a mess in the US, unfortunately. It
Not
really
great up
is.
here. I'm not gonna
It's
lie.
not great up there either. All right, well, yeah, but yeah,
Free, but
but
it's not
it's
great.
it's a hell of a lot cheaper. That is for
Yeah.
sure. Yeah. so, um, so anyways, yeah. So I started out in a regular routine medical practice where you just see patients and you get compensated. The more you see, the more you make. And then for years that worked and that was fine. And the system was working well. But the system is, our system is really geared towards specialists. There's every incentive to get people to go to specialists, from the training that says that, if you haven't gone into a specialty, you haven't really reached your potential, and the specialists are paid extensively more. Specialists are revered more. They're looked upon as experts, and they get speaking opportunities. There's just a lot of incentives to specialize in medicine. And so, primary care is sort of getting the shaft. And as a result, there's not that many people going into it. So we have an incredible lack of primary care physicians. And
Wow.
as that number goes down, the demand goes up. You need to see more and more patients, which makes it less sexy, which means that you get busier because there's more people clamoring for one primary care doctor. And it's just a snowball effect, unfortunately. And there's
Wow.
some efforts to go about changing it, but they're not really very effective right now. The interesting thing is, I'm in the Washington D.C. area. We are apparently the highest number of physicians per capita of any other city in the world. Yet we are also considered medically underserved when it comes to primary care.
Wow.
I
It's
never
just a
heard that.
staggering statistic. So, it's unfortunate that that's the reality. And so I was seeing patients on my own, with a fairly medium-sized practice, and we were doing great. And just because of legal reasons and reporting and insurance requirements and so many things that are happening that make it difficult to practice medicine. You need such a big team of people. It became harder and harder to be an independent practice. And so the majority of practices over the last 10 years have gone with large entities, hospital systems or
Mhm.
Goldman Sachs and whatnot. So my practice was purchased by a large hospital system. And then when that happened, bureaucracy just became overwhelming. You had no say. At least in my old practice, it was busy and there was a lot of administrative responsibilities, but we had control. We could determine what we want to do, how we wanted to do it. And as soon as the big hospital system took over, that was instantly removed and it became untenable. So I moved over to this concierge practice, which is becoming more and more popular in medicine in general, but especially in our area, because you get to spend time with your patients. You get to
Wow.
practice medicine. You have say in what you do. You have longer appointments. You get to know your patients, and I can do that behavior change where I can sit down with an appointment and spend the time with them and explain what they should do, how they should do it, how to get them to do it. And it's medicine the way we were taught and the way it was intended. So
Can you
Wow.
explain how concierge medicine works? Just for those listening that aren't familiar with the model, can you give a little bit of a rundown there?
Like right,
sure.
like kindergarten level. Like
Yeah.
go.
So it's a membership. It's sort of like Costco. You get but I'd like to say on a much higher scale, on a more classier scale maybe. But you pay a membership, and with that, then because of that membership, you get some guarantees along with that, with longer appointments. We'll have a limited panel. So, I have about 1/10 the number of patients that I had at my last practice, which is much better. I get to know everybody. So you have longer appointments, longer physicals, access to me rather than an urgent care or physician assistant, nurse practitioner, or somebody who doesn't know you. So it just creates a more personal type of medicine. And it's like medicine was probably 30 or 40 years ago.
Yeah.
You had your
Yeah.
local community doctor, and you would just go to them. You always knew them. You always talked to them, and that's the way it works now. So because we don't see nearly as many patients, the insurance reimbursement is not nearly good enough to keep an office open in that respect. So there's an annual fee that goes along with it to make the
Yeah.
model viable.
That's so interesting. It's such a good point that I even think back to when I was growing up. As a kid, I had my doctor. Like it was
Right.
my doctor, and
Mhm.
he knew me, and I knew him. And That doesn't happen anymore. There's so much interesting stuff that you just shared there. Like even going back to the push to specialize in school. I'd never heard that before. I had never
Yeah,
heard that. I've heard of the doctor shortage, and I thought to myself, well, like, what's up with that? But it's specifically primary care doctors aren't being. It's just not being encouraged in the
right.
educational stream. That's wild.
Yeah. Well, the other thing about it too is I thought was really interesting. So I teach at Georgetown and George
Oh,
Washington universities, and the residents tell me, and I've corroborated this. Another reason why they don't go into it is because they feel like in primary care they have to know everything.
yeah.
And so, and they don't want to know everything. They want to know just
One
a
thing.
little bit very, very well. And that's a
Yeah.
lot easier to manage. I
So
love trying to know everything, and nobody's going to know
right.
everything. Nobody, there's no way. But the information is all available.
Mm,
And if I don't know something, I have specialists that I can refer to. I mean, there's wonderful things, but I love learning new things. And I always
mm.
call it, say that I've medical ADD. Like I can't just focus on one thing. I'd be bored, you know. So I love having a different thing every time that comes in every day.
Are we overrun with specialists then? Is it just like
Yeah,
we are?
again, I
Oh,
don't know what it's like in Canada, but yeah,
yeah.
it's yeah, you can't swing a dead cat without hitting a
Oh,
cardiologist
wow.
in this area. So
Okay. Um, okay. So my brother-in-law is actually a primary care physician or a
yeah,
general practitioner, I think is what we call him up here. But it works for him because he lives in a small community. So it was like that was the only, and he wanted to serve a community. So he that really does work in that small community thing. But it does sound like in these larger centers, it's just not worth it. That's wild. That's very interesting. So I want to go back to the way you described the concierge service was amazing. So
Mhm.
you get longer appointments, right? Longer appointments, more attention, sort of more direct and personal access. That's great. So the reason why I think this is interesting, and I have a question for you about this, is because like health coaches and those of us who are kind of working on the fringes of the healthcare system, we know that doctors don't spend a lot of time with their patients. And sometimes we get a little bee in our bonnet about like doctors only spend 7 minutes with their patients. And what Laura and I know, and some
we have a
people
bee
who
in our bonnet about it too, by the way. We
yes,
don't, you know, doctors don't like that. So,
exactly.
yeah,
That's one of the points I want to make is that people who are paying attention to doctors realize doctors aren't really into that either. It's their doctors aren't the jerks here that are kicking people out of the office after 7 minutes. It's all part of the system. But my question for you is like, so to me as a health coach, longer appointments sounds great. I would love it if my clients could have longer appointments with their doctor. But do patients really value that? Like, is that one of the things that they're looking for? Like, I want to be able to have a conversation with are you finding that patients are really picking up on that?
oh, absolutely. Oh, they would love it. Yeah, no, it's the hardest thing in the world to cut somebody off, and you know you have three other patients behind, you know, and you're running behind, and it's not fair to the next person. But this person has real problems, and they have real questions, and you just can't answer them all. And it's so hard, and it's heartbreaking because you want to answer them all. You want to help these people, and you want to help each one. That's why you go into medicine. It's why we do what we do. And so it is really, really tough. And the only answers are to either cut them off or to screw the next person because then they're not going to get enough time, or to run an hour behind all
Right.
day. And you know, and
Yeah.
there's none of them is a good option.
No.
And so, so this is the alternative, and this works now. Obviously, with concierge medicine, it's not a perfect system either because not everybody can afford that, and so it does limit who you
Right.
can see, and that's unfortunate too. It takes out a lot of diversity. A lot of my previous patients who I loved, I was able to bring some of them on without charging them, but you can't do that for everybody, or else the
Right.
model doesn't work. So, yeah, so there are limitations with this one as well. There is
Yeah.
no perfect model that anybody's really come up with yet.
So I would love to dig a little bit more into this because so I would imagine the membership fee is not reimbursable by insurance, and I do know some concierge doctors don't take it at all unless it's things like blood work or getting tests or X-rays or something like that. But and from my experience, I was doing more like it was a concierge service, but more of a telemedicine model.
Mhm.
My doctor didn't live near me, where I didn't have to pay for appointments either. I was paying one monthly fee. I didn't have to pay for appointments.
Hmm.
And so here's the thing though, since I was paying this monthly fee, um, the concern that I had, and I was asking him, do you find people are just booking appointments willy nilly all the time because they can? He's like, you know what? Oddly, no. That occasionally happens, but most people just they book appointments when they need it, and they know that they're going to get me, and I have my schedule, and there's really no like I feel like I need to get my money's worth out of it. People are investing in this because they value the difference in the experience. And so he personally didn't take insurance or anything like that, but we could bill insurance for other things, like any blood work that I needed, if I needed to go get a mammogram or something like that. It kind of covered all that. So it created like a nice little hybrid model. And then it had me rethinking where I went for insurance. Right. And looked for a different kind of plan, because the other thing that they could offer was for folks that didn't have insurance. I mean, I would love your thoughts on kind of how you navigate this, being able to negotiate cash pay prices for certain testing and things of that. Would you mind speaking a little bit about kind of how this model works within the insurance system so folks can kind of wrap their arms around how it works?
Yeah. So what you're describing is called a direct primary care, or DPR. Okay. And that's actually taken off too. And in a lot of ways, it's even better than what I'm doing. Because it goes back to the old style of medicine back in the 50s before insurance ever came around, and it takes out that middleman, because insurance is expensive. Yeah. And there's thousands and thousands and thousands of people at insurance companies who are looking at every claim and trying to block this and come up with this plan. And there's a huge amount of fat in the system that goes into everything that you're paying. When you're paying into insurance, you're paying for a lot of those people. And so the DPR system gets rid of that, and just is just a connection between you and your doctor, and then becomes, much more of a free market system. Because in the regular medicine, you see the patient, but your employer pays the insurance. There's no free market system whatsoever. There's no incentive to improve or to have the free market exertion that would create changes. So in the DPR, it's a better model from that standpoint. And one of the probably future ways that things are going to go, if they can incentivize it, but I think this is a really good way to go, is to have you pay directly to your primary care doctor, not get insurance involved at all, and then get a catastrophic insurance plan, so that you pay a little bit monthly to your doctor, and you pay for a cheap insurance plan that if you go to the hospital, get paid for. Right. There is a donut hole where you would be stuck for things like labs and x-rays, and God forbid, if you have to see a specialist, it can get very expensive. So not everybody's going to fall into that realm where it works for them. But if you're young and healthy, or even older and healthy, that could be a really good model for you.
Cool. And so that's a different model than what you practice.
That's a different model that we're practicing.
Do you mind kind of contrasting the difference?
So what we do, ours, they're both, monthly or annual fees, however you do it. Both are membership models, but in my practice, we still take insurance. And so we have people who have regular insurances, and then they pay a little extra so that they can get, the more time, the personalized care. And in the DPR, it's people who either don't have insurance or just have catastrophic plans, or may just have insurance and want their doctor just happens to have that kind of model. The insurance is taken out of the picture altogether when they're seeing their physician. It is just a direct cash pay right to them, and it doesn't matter whether you have insurance or not. That has no factor whatsoever. So if they have insurance, they can use that, like I said, for labs or x-rays, or if they need to see a specialist. But when you're seeing the physician, insurance is completely kept out of that connection.
Yeah. It sounds like your model is a nice hybrid of how people that are fortunate, perhaps they've got, employer sponsored healthcare. So the premiums aren't as bad as they are for someone like us, that small businesses where we're paying astronomical premiums, things of that nature, but they still like the idea, and they've got the discretionary income to pay a little more to just have a much more sort of private and personalized approach. So thank you for differentiating that for us.
Yeah, and it's going to be different for each person. It depends on what their needs are, what they want, who's nearby, who they like. So I think there's a model for everybody out there, but there's not one model that fits all. There's not one size that fits all.
Yeah. Sounds nice. It sounds like you have some flexibility too as the clinic owner and director to make it the way you want it, I guess, in
Yeah,
some ways, right?
it's
Yeah.
it's really important to have some self-efficacy, to have some say in what it is that you do. And, I think everybody wants that. Nobody likes to be told what to do and how to do it. And so, especially physicians, we can be a very opinionated and belligerent bunch. So we have very, very strong opinions of how things should be done. And so when somebody from, an ivory tower comes and tells us this is how you're going to do it, and you have no say in it, it's tough to work under that kind of a model.
Amazing segue
Yeah.
because self-efficacy is the outcome of health coaching. So if we go back to kind of, I know we've kind of been talking a lot about this hypertension sleep connection you've made, and there's a ton of other chronic health conditions I'm sure you see, and a ton of other behavior changes that you encourage. But I'm curious. I'm curious about a few things, like just in terms of process, like who do you have on staff? Like, what does your staff look like? Who are the practitioners that are working with you? Do you have health coaches or other nurse practitioners that are encouraging this? It sounds to me like you're doing a lot of the coaching, to be honest with
Yeah.
you. So can you describe sort of how we go from, and just using this as an example, if we have another example, please feel free to offer it up. But like, hey, hypertension, let's work on your sleep and let's get you like, because that's actually one of the harder ones to work on. Just put that out there. When your client comes to you and said, and you've uncovered that sleep is maybe one of their hurdles, that's actually one of the harder behavior changes just to work on, because they have to kind of go off and do it on their own, really.
Right.
Like you can't
You're
even
right.
offer recipes or whatever. You
Right.
just have to go and do it and then report back. And there's a lot of going and doing and reporting back. So I don't know, take us through kind of how you are working through some of these behavior change pieces and who you have on staff that helps you with that.
Okay. Yeah. Yeah. No, that's great. And actually, that's a wonderful thought. Actually, we have coaches that we can send people to, but we don't have one on staff per se. Yeah, we do take it on ourselves, but it's actually a really good thought now that you say that.
You know a few coaches that if you're
Yes, I'm
looking to
sure you
hire
do.
some.
Sure you do. Yeah. So yeah, no, and so we do send people to coaches. So we have in our office, she just contract space, but we do have a trainer, personal trainer.
Hmm.
So we have somebody who can help you with exercise. We do have she's not technically a dietitian, but somebody who can help with weight loss and diet. And she also is not part of the practice, but rents space from us. But we want to incorporate that in. And then we have a number of people that we refer to that can help with these kinds of things, like health coaches and sleep specialists, people who are specialize in what's called cognitive behavioral therapy for
Mhm.
insomnia. So CBTI is a big thing, and so we have people in the area that we can refer to help with these things. But mostly, you're right, it is on us, and I think it would be great to have some support in that realm, and maybe we'd look into probably having somebody on staff. The other things we have, with being concierge, we also have a lot more nursing staff per provider than the
Mm.
average office. And so that's another way we want to make sure that we have our staff reaching out to patients saying, hey, did you remember to make your appointment? Did you remember to take your medication? How are you feeling today? Making sure we have that follow up. And so we really encourage that and make sure that we have a lot of that, a lot more so than you would have at a regular
Mm.
office. So we have a lot of support staff with us
Mm.
to call patients and reach out and make sure everything's going okay. And I think that's another really important thing. Communication is such a critical part of good care. And so we want to make sure that we have really good open communication. So we have a portal and emails and phone calls and telemedicine, in person, nurses reaching out and texting. And we want to make sure that there's all kinds of good open channels of communication to make sure that patients are reminded of what they're supposed to do and are able to get in touch with us if they have questions or they need something.
Interesting. Yeah, I mean, like a health coach is a person, but health coaching is a practice.
Right.
And it actually sounds like you've got it in sort of a deconstructed manner, sort of scattered throughout the practice, right? You're doing some of it, the nurses are doing some of it, you get the nutritionist person, you get the trainer. And the communication piece is a big part of what we do, keeping people on track. You're here, we're going to move you now to this next step, and now we're going to move you to the next step, and we're identifying barriers and helping them overcome them. And it does sound like you have that built in, even in the absence of a proper health coach. But that is really, I have a student that I taught in our advanced coaching course who went to work at a concierge medical clinic. And the way they did it was after she left the patient left the doctor's office, and the doctor was great because the doctor had tons of time to hang with this patient. the patient would immediately go to see the health coach, and the health coach would say, what did you just learn from the doctor? And have the patient describe in their own words what they understand about the appointment. And like, well, what don't you understand? And so what are you going to do moving forward? What are your barriers? What's your confidence level? Are you lacking resources? And and then you have the nursing staff that follows up with the appointment piece. And it's just that person is cared for all the way through. It's really lovely. It sounds like you've got that going pretty well in your
Yeah,
practice.
well, I hope so. Yeah, no, you're absolutely right though. It's so funny because the big joke in medicine is that you have somebody come in and they have whatever it is, and you say, blah, 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 blah. You don't have cancer, blah, 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 blah. And all the patient hears is cancer, and so, and so, I have this reputation. I have this notepad, and I've gone through thousands of these little notes that say from the desk of Dr. Kenneth Zweig. And I have there are thousands and thousands of these all over the DC area, because nobody leaves my office without one of them, because I will always remember when I'm in residency, one of my attendings saying, patients, you might be with them for 15 or 20 minutes. They only remember one or two things, or they may not even hear that. And, you don't always know what it is that they'll take away, but they're not going to take away everything. And so I always say, well, then they're going to take away the important things. And so everything I want them to do, I write down and as a little summary of what we talked about, and give them take away, because
Also,
they can't say that. Yeah.
Also, just the fact that they're not being hustled in and out. There's something about that high pressure environment. Like, okay, I've got 7 minutes with this doctor. I got to make sure I absorb everything and understand everything. And you just can't, and you're kind of in this panic state. Right. So even just the calmer pace of the appointment probably helps a lot. Absolutely. But there just is always a bit of a communication gap between what doctors say and what patients hear and understand, as Absolutely. You well know. Yeah. So it sounds like you're really taking the time to make sure your patients get it.
Yeah, it's great. One of the nicest things about switching to this new practice is that, I can say, is there anything else I can do for you today? And it doesn't strike fear in my chest. Used to, if I had to say that, it was the most terrifying question I could ever possibly
You're looking
ask.
at your watch. You're like,
I know it would just fill me with dread. And so, but I didn't want to leave without asking that, but it was just an awful, awful question for me. And now I can say it and happily say yes. And if they say, yeah, there's one more question I have, I go, okay, great. And it's just so nice to be able to have the time and really, make sure that we've finished the appointment. I never felt like I finished the appointment before. It didn't really feel like practicing medicine. I just felt like I was surviving, but now I'm back to practicing medicine again.
That anecdote you just shared is very stressful. It feels very stressful to hear. The doctor kind of half out the door. Is there anything else I can do for you? Because you want to help desperately. That's why you did it. Yeah. Right. That's why you went into medicine, to help people. But in the back of your head, you're like, you got to say no, because I've got, oh, that feels like I feel the stress and the pressure of that just inside. That's difficult. We've heard that before from other doctors on the podcast and I think that's, again, because I'm in Canada and I have no line of sight on things like insurance companies. And, although to be honest with you, the experience of going to the doctor is the same here. The insurance company is just, Health Canada. It's just different payee, I guess, or payer. But like I learned that when we spoke to Dr. Kim Foster, she was the first one and she's also a Canadian doctor, but not that matters. She said, we're not even allowed to spend time. We can't. We want to. That's why we did it. But the system is set up to not allow it. And the pressure and the stress of that before then had not been known to me, and I feel like we just have to give doctors a little bit of slack, because sometimes in the health coaching space and in the health zealot space, we come down on doctors like these damn doctors don't spend enough time with us. But anyway, you want to.
When in reality, it's not the doctor. I would love to hear what your goal for the patient experience is like now for you, from patient appointment to patient appointment, and I would love for you maybe to describe what a typical patient conversation sounds like. And I'm sure everybody listening can then contrast that to their last experience through a conventional model and the differences.
Yeah, that's a great question. Yeah. So what I hope the patient experience is that they feel cared for, that they feel listened to, and that they got what they needed out of the appointment. Right. And so, and that they feel like there's a connection, because, it's hard. It's interesting because I've had a number of patients follow me to this new practice, and I would see somebody for 10 years at the old practice and then see them at the new practice and have a longer appointment and find out all kinds of things about them that I never knew before, because we never had time to talk about them as a person, just their medical issues. And so I find out all these fascinating people. I have very fascinating patients, they do really cool things. And I thought, I can't believe you never told me that, and so it's really cool to get to know them better, and you get to know somebody, and that creates a better connection with them. And then the more connection I have with them, the more they trust me, and the more likely when there is that trust, also they're more likely to do the things that I ask them to do, because they trust what I have to tell them. And so it makes for a better experience on their part, makes for a better experience on my part, makes me want to just help them even more, because now I know them much more as a person than as somebody who's getting in the way of me and getting home before 10 p.m. And so it really is just, it's a nicer experience on both sides. And so my hope is that when they come away, when they go into an appointment, that they have expectations, and that those expectations will be met by the end of the appointment.
I love that. So here's a question I have. Is everyone that's all of your patients in your practice, are they all local to you and you see them in person? Are you doing any kind of telemedicine at this juncture? The reason I ask is because we get a lot of questions from coaches, like, with a desire to want to refer clients to a practitioner they trust, and there's no one local to them. So, more and more are now able to do more kind of telemedicine and be able to do this stuff remotely. Can you speak to that about your practice and how that fits in?
Oh yeah, it's taken off with COVID, obviously, and telemedicine. My old practice, we were talking about doing telemedicine for years. We said we should do it. We really should do this. This is such a good thing. Why don't we just do it? And we just had all these ideas and everything set up, and we just never did it. And so then COVID hit, and within 2 days, we had it set up and ready to go. And so we've been doing it now, for the last 2 years, and it's actually worked out much better than I had ever thought. I thought really some dermatology and psychiatric care is all we were going to be able to do, but actually we can take care of a lot more than that. Is, you just teach patients to do the exam. They can do a lot of orthopedic exams and maneuvers themselves and say, does that hurt if you do this? Or, what does that feel like? And so I can actually address a lot more things than I had thought. There's still obvious clear limitations to telemedicine, and sometimes you just have to have the patient come in. It does not replace an in-person visit, but it does have a definite role, partly because a lot of patients will just ignore something because I don't have the time to go in. I don't feel like doing this.
Right.
But if you have a telemedicine and they don't have to leave the office or don't have to leave the home, they're a lot more likely to make an appointment and get something addressed. So that I think really helps. And also because of that, I have a lot of patients. We're in DC. People travel all the time for work, for pleasure. I have patients that live in Connecticut and Montana for the summers, or Florida. I have a patient who's full-time in Florida, a couple patients who are full-time in Florida and Texas and Colorado. I just talked to somebody yesterday who's in Poland for helping out Ukrainian refugees. So which is really cool. I was really proud of her. And so there's a huge role for it, and it makes it more interesting too when you get to see people in so many different settings, and that they're able to stay with their physician even if they're not in town, and address something if they're thousands of miles away. So telemedicine has really opened up a lot of doors.
What are you finding is actually really well managed or doable via telemedicine that you didn't think you could do before?
Well, like I said, the orthopedic things were much more.
So you're actually instructing people to do their own
Exactly. Yeah. I say, okay,
examinations on
here's, turn your head this way, tilt it back, take your hand, press it down. Does that hurt? Take your arm, move it up like this. And, so they can, so there's certain maneuvers that you do for different joints to tell what's wrong. And so you just teach them how to do it and say, does that hurt? Or press with your other hand and see what happens.
I guess I would imagine that in some cases, the initial assessment or appointment is probably better done in person, but any follow-up appointment almost would be easier to do. Yeah,
a lot of times, like a follow-up for blood pressure. A lot of this with the telehealth is a lot of they're putting into a bigger picture of telemedicine. Right. So having somebody who has a blood pressure cuff at home or a pulse ox, or and so they can do their own assessment for some of the vitals and different things. And so if somebody's checking their blood pressure at home, they have their own blood pressure cuff, and it's appropriate for a follow-up blood pressure. Absolutely, you can do it by television.
Go ahead.
On the topic of self-efficacy, that's so interesting. Like something like blood pressure, which by the way, you can go get that, stick your arm in the thing at the drugstore, whatever. Um, but an actual patient, we're just going to go with this blood pressure thing again. It could be anything, could be blood glucose, could be, what else could it be? Anything else, some metric, some biomarker, but teaching the patient to do it themselves, explaining to them, this is what you're seeing, this is what it means. That's very empowering. Because
Absolutely.
normally you go to the doctor to find out that stuff. And
Yeah.
some of the, like, how empowering to be able to just kind of do it yourself, or even
Right.
orthopedic exam. Like, I just
Yeah.
love that from an empowerment standpoint.
Oh yeah, I'm a huge proponent of patients doing their own monitoring. And there's lots of evidence to support that. You know, people who monitor their weight
Mhm.
lose weight just by checking it. People who check their blood pressure do better with their blood pressure just by checking it. People with high blood sugar, diabetes, if they check their blood sugar, they do better.
Yeah.
I would say you get grades in school. Nobody would do their homework if you didn't get grades.
It's like
So just
budgeting.
by getting that feedback, getting having that those metrics really helps you do better. But you're right, it's also a matter of self-efficacy of empowering yourself to do it rather than relying on us once every 6 months or so to check things.
Yeah.
Right.
Yeah, I mean, I have my own blood pressure cuff. I have my own blood oximeter because when my whole family caught COVID, I was like, okay, for $20, I got a blood pressure cuff for $20. I got the blood oximeter for about the same. Even blood glucose monitors for because my husband's he's having some blood sugar dysregulation issues that we didn't realize were there, but I happened to have one at home from when I was pregnant with my twins in my 40s and tested positive for gestational diabetes. So I had that and we had him checking it and he was really surprised by how high his fasting blood glucose was. But then it allowed us to be like, wow, that's concerning. Perhaps I should ask my doctor. But we were able to find all that out ourselves for less than $100 in buying these things to keep at home that we can then actually now have a conversation with a practitioner that can help us dial that stuff in. So the standpoint of, to your point, being able to track this stuff that then prompts a behavior. Gee, I should be concerned. Maybe I should talk to somebody. Or, oh, maybe I was concerned about nothing. Everything kind of looks fine. Let me just ask my doctor and make sure that what I'm feeling is accurate. And it kind of adds some clarification to that stuff. So I think that's fantastic.
Yeah, I'm a big believer in it. Yeah.
So where do your clients come from then? Because with traditional insurance, well, you do accept insurance, but I would, people are always looking for doctors who are in network. So most of your clients today came from your prior practice. I love to hear that so many of them came over with you. Where are your new patients coming from? Are they by referral, databases?
Yeah, mostly by far, it's mostly by referral, word of mouth. There's there's a few we try to have a pretty good presence online. So I write a blog. We have these podcasts. We're doing our own podcasts. We do some town halls and things. We try to do things to educate our patients, and it gets out online. So some people find us that way, but the majority of it is word of mouth. I mean, yes, there is telemedicine, but still, by far, most people find their physicians because they're close by and their friend told them about that. And so, it's really, really mostly word of mouth. It's changing to a small degree, and there's certain models out there. This one was started by a former Google exec. It's based on very high tech. It's doing a lot of interesting things, and so some of those are getting some of the younger patients who are more interested in the high tech side of medicine. Right. But like I said, for the most part, it's really word of mouth.
Yeah. Yeah, I mean, like there's a large percentage of folks who aren't ready to leap into high tech medicine. They're like, I like the old school doctor patient paradigm. I just wish it was a bit more.
Right.
We need to have a soft place to land for those people. Interesting.
Right. And I don't think technology is ever going to replace it because people are different. Everybody's different. There's no one size fits all in anything. We just play the odds, and you might have a medicine that helps with 85% of people. That's a great medicine. But what happens to those 15%? A computer's not going to be able to figure that out. Or maybe somebody doesn't think that the condition is bad enough to warrant a medicine because they don't like taking medicines. Again, it's not going to, technology is not going to substitute that. There's something about the connection that we have. We're social creatures, and, people want to be with other people. And so it really makes a difference having that personal connection to make medicine really work.
Yeah.
What technology do you think is helpful versus some technology that you see that you're a little like, I don't know how accurate that really is? Or maybe because, we were interviewing our founder, Mark Sisson, about some of this technology. And his first question is, okay, so first of all, what are you going to do with the information? Is it really going to impact the choices you make and how you handle a condition or a situation or what have you? But there were a couple pieces. He was like, that sounds interesting.
Mhm.
Or that whatever might be a bit of a waste of money because he's not so sure. Like a lot of the, for example, a lot of the stool testing technology that's out there. We've had people that did some experiments, did 3 or 4 different companies, and they all came back different, exact same sample.
Yeah.
Same thing with food sensitivity tests
Right.
and things that may be not 100% accurate and some of the, I guess, limitations of that. But is there some technology in certain tests that you do think are valuable and meaningful and others that you might kind of pass on right now or that you don't recommend regularly?
Yeah. So I will say I'm a little old fashioned, and I'm not a big fan of high tech in most respects, especially when it comes to medicine. And maybe that'll change in the future. But right now, I think we have a reliance on technology in medicine that's far, far, far too big.
Mhm.
I would say the most expensive test you can do is this, because this costs a couple $100,000 going through medical school.
Mm.
And it's going to be always better than an MRI or a CAT scan or anything else that you'd be able to do. So, you have to look at the patient first. And, we have an incredible reliance on technology. But I always tell my students, the only thing that's 100% in medicine is that nothing is 100%.
Right.
There will never
Mhm.
be a perfect test or a perfect treatment that works for everybody. It just doesn't happen. It doesn't exist, and it never will, because people are just too different. And so you have to use some thought and some a lot of logic and personal touch to make medicine work. Tests are only as good as the person who reads them and interprets
Yeah.
them. And so there are a lot of limitations with that. But
Mm.
I think some of the things, but that doesn't mean technology doesn't have a role. I think things like Fitbits are great. That's another one that gives you the immediate feedback. The fitness trackers
Mhm.
are wonderful, and people really pay attention to them. My daughter's obsessed with it. Hers, she's always like, "I got 14,000 steps today," and so I think those are really helpful. Again, I think telemedicine definitely has a much bigger role than I had originally thought it would. Home monitors, anything that gives you feedback, I think is really helpful. Reminders, just using your phone as a reminder for, hey, it's time to go to bed. Hey, it's time to go do a 15-minute walk or get up and stretch if you've been working this whole time and just sitting too long. So it really depends on how you use it. And I think technology has a role for the individual to
Yeah.
help them make some behavior changes. And it certainly obviously has a role in medicine as far as labs and
Hmm.
there's all,
Yeah.
all kinds of implantables, and there's an incredible amount of technology that we can use in medicine, and it absolutely has a role. But you have to. A lot of people, I don't think, really understand the limitations, and really, even physicians, I think, rely on it far too much, without knowing that
Yeah.
there's a lot of limitations with this, and there's nothing that beats a good history and physical exam.
Yeah, that's what I was gonna say. Like, what about just asking the client how they feel, or the
Right.
patient, sorry, how they feel?
Right.
I think about, I have a little 11. So I have a client right now who's 11 years old. And so,
Aw.
he's, as far as communication goes, it takes a while for him to like really articulate what is going on. So, but that's fine because I've got all the patience in the world. And so Riley was feeling tired. And we were talking about, well, what have you been eating? What have you been sleeping? Have you been playing more sports than usual? And we were going through all the whole things, and then having a really just doing a lot of active listening. Just tell me, Riley, about what's going on. And long story short, it turns out that Riley is stressed out because his homeschooling schedule is too intense. And his mom was on the call as well. And she said, "Oh, I had no idea I was stressing Riley out." But like if we had just said, well, Riley's tired, let's change his diet. Riley's tired, go to bed earlier. But I had to listen to Riley to find out that he's just under pressure, the poor little guy, right?
Yeah.
But like I think that I guess symptomology, the client's lived experience is the ultimate technology that sometimes gets overlooked.
Right. No, absolutely. Oh my God. I always say if everybody did what they were supposed to do,
Mhm.
I'd be out of business, but I've
Mhm.
got job security,
Yeah.
because we're stressed out, we don't sleep enough, people don't eat right, they drink too much, and it's human nature, and it's hard to get them to change and do the right thing.
Yeah.
But if they did, people would feel better. And so much of this, so often people have abdominal pain and they get a CAT scan and they go get a colonoscopy and all these other things. And really, yeah, it's the same thing. You're just stressed out. If you
Yeah.
just talk to the patient and listen to them, you would know that from the very beginning.
Yeah. There's just a general, I guess people are bewildered. And I
Yeah.
think they're bewildered because they haven't had the opportunity to have proper conversations with their healthcare team. So this is awesome. I love hearing about stuff like this. It feels really hopeful and kind and necessary. And I love the way you did it. Was like you just kind of decided to do it. Like I don't get there's a strong sense of bureaucracy in the way you operate. Like even when
Oh,
you
not now.
described
Yeah.
going to telehealth, you're like, well, we did it in 2 days. We was like, "Okay, we'll just try it, and we did it in 2 days." And it's like,
Yeah.
yeah, you can just do whatever you want. Like
Right.
if it needs to exist in the marketplace, make it. And I think maybe, I don't know if a lot of doctors might be maybe afraid to do that. But it looks like to me that you're paying attention to what patients need, what the general population need, and you're delivering it, which is just outstanding.
Yeah.
It's great.
Yeah. Thank you. I hope so. That's what we strive for. But a lot of doctors are just not empowered to do it. Once like I said, we went from, I believe it was 40% of physicians 10 years ago were under a large conglomerate of a hospital system or insurance system. And now it's up to about 75%, I believe.
Wow.
And so, most doctors and people in doctors in that kind of a system, they don't have the empowerment to make those kinds of changes or to do what patients want. And,
Right.
Yeah.
it's very frustrating being in that
Yeah.
situation.
So we need more doctors like you. I mean, so are you happy with kind of where things are and you're just looking to try to serve more people? Are you looking to expand, maybe bring in other doctors or other practitioners? Like how do you see the future for you and your practice specifically, or just the concierge medicine model moving forward?
Well, I think concierge is growing like wildfire
Yeah.
because, like I said, the people are seeing the writing on the wall and they're just not getting what they need from the standard model. And so many people are coming to me, and I've had a lot of patients who didn't want to pay the membership fee and decided to go back to the old practice and realized, oh my God, this is just not working. I'm absolutely, please take me back, and
I
so are
bet.
coming to me. And yeah, we're looking to hire probably 2 more physicians because we have a long waiting list and people really are clamoring to get into this type of model. So yeah, so there's absolutely a role for it. Except the other part of it though is that for every physician that leaves the standard model to go into the concierge model, that leaves, hundreds or maybe thousands of patients behind without a physician.
Yeah.
And that's where the problem is. And so
Right.
I think what the answer is to figure out a way to incentivize primary care physicians or students coming out of school to go into primary care and
Mhm.
make it sexy, make it lucrative.
Right.
You have to make it desirable. Not everybody who comes out of medical school can go into dermatology. So, but that's what
Yeah.
they're all looking to do right now because it's good hours and good pay, and not a lot of call, and and you get to do a little surgery or whatnot. But it's to me, it's not too exciting.
Yeah.
I would hate to do that, every day, day in and day out. So, there's got to be a way to make it uh, incentivized for
Yeah.
more people to go into primary care. And if there are ways to do it. And we also want to get the best people into primary care because then if you get people who are smart and motivated and intelligent, then you don't need as many specialists.
Right.
If you have more time, one of the nice things about what I do is also I have more time. I stay on top of the medical knowledge as best I can, and the more I do that, the less I have to refer somebody out. So in the long run, it's actually cheaper for the system. It may not be cheaper for the individual patient, but for the
Mhm.
system, I'm not doing a ton of tests and a ton of x-rays and labs and sending them to a specialist because I don't have time to address the issue. I have time to address the issue. And as a result, I didn't send them to a cardiologist to get, $3,000 worth of tests. And it's been shown that model in total is actually a lot cheaper for the system.
Yeah.
So hopefully
Yeah.
that'll be recognized eventually, and something will be put in place to help incentivize this going forward.
Yeah,
Hopefully.
it makes me, if systemically it's less expensive to the system, that will eventually filter down to the end patient. If insurance companies realize, gee, if we help compensate a membership fee or pay for a health coach or pay for gym memberships, that's a heck of a lot less expensive than paying for type 2 diabetes for 20 or 30 years once people adopt that.
Yeah, and they're starting to. The insurance companies are getting that message. They are, giving people discounts if you have a gym membership, or you can show your step counts,
Mhm.
or you see a dietitian or a health coach. Some of the places are having health coaches that are
Yeah.
on their staff, and so it's starting to come around. It hasn't, and in some ways there are incentive programs for physicians too, where they get bonuses if you can show improved outcomes.
Yeah.
The problem with that is, how do you show an improved outcome? Is it because you just had a healthy patient base to start? How do you show that your patients got better? And, they want it all to be documented. And so then you have to spend twice as long putting that information into the computer so that they can pull it out in the right way and say, oh, yeah, your patients look better. But then, is it worth the money if you spent an extra 2 hours a day checking the right box? And so it's not really
Mhm.
necessarily better medicine, it's better charting. But that's not the same thing. So, there's work to be done.
Yeah. Yeah, for sure. Well, I've loved this whole conversation. It's just so refreshing to hear this approach being, I guess, taken up by more people in a recognition, and that you're here to be able to personally speak to, first of all, better quality of life for you, better patient experience, as well as your own just sort of, I got to imagine, professional fulfillment, right? And
Oh,
just,
absolutely.
yeah, just how much more you enjoy your job. And I talk to doctors a lot in my role. The other people I talk to a lot are nurses that are
Right.
sick and tired of the conventional model and want a different approach, that are actually looking to leave nursing entirely at a time when we need more nurses. Perhaps if this model takes off at a greater speed, and it sounds like it is, there's going to be another option for nurses as well to be able to take on some of these roles, do more coaching, that sort of thing. So I guess I'm leaving this conversation with more optimism,
Oh, good. That's great.
which, yeah, I
Yeah,
love it.
that's
And I
good.
hope our
Yeah.
listeners do too.
Oh, well, that's fantastic. Well, I hope so. And, I think there are things that can be done. It's a matter of, how do you get them done? Like behavior change, it's the same thing. We know what we need to do. We just don't know how to do it. And you can't turn a battleship on a dime. So this is just a massive, massive part of our economy. And so getting it to change course is hard, and you have to have a lot of political will and financial will, and a lot of people have done very well and very successful off the current model. So
Yeah.
there are a lot of incentives to keep things as is, and that's part of the problem. But there are things that we can do to make things better, and we're trying to do our little part.
Great. This is wonderful. Thank you.
Yeah. So tell me a little bit, like, where can people find you if they kind of want to follow what you're doing, what's happening with concierge medicine? Perhaps they want to become a telemedicine client or a local client, a patient. I kind of used the right term there. So where can people find you, follow you? You said you had a blog. Fill us in.
Yeah. So all that can be found on my practice's website. It's N as in Nancy, VA, familypractice.com. And on there, we have my blog, we have a lot of videos and what we call town halls, which are ways of educating people. We started doing that about COVID, educating them about COVID, and then we've moved on to all kinds of other health topics, so that you can go on there and watch videos from specialists and people that we know in the area to help educate our patients about whatever topic it is they're looking for.
Great.
Awesome. Love it. Thank you so much, Doc. This was so great.
Oh, great. Thank you. Yeah, thank you. This was a lot of fun.
This podcast was brought to you by Primal Health Coach Institute. To learn more about how to become a successful health coach, get in touch with us by visiting primalhealthcoach.com/call. Or if you're already a successful health coach, practitioner, influencer, or thought leader with a thriving business and an interesting story, we'd love to hear from you. Connect with us at hello@primalhealthcoach.com and let us know why we need to interview you for Health Coach Radio. Thanks for listening.